All right, hello everyone, and welcome to this first webinar for the PNQIN AIM Perinatal Mental Health Conditions Bundle. We're so excited for our agenda today, and we're going to get right to it. And for those who don't know me, I'm Kaylee Vitek. I'm the PNQIN Project Manager for Obstetric Initiatives. So again, welcome everyone. For attendance purposes, please type your name and institution into the Zoom chat. We like to do some optional shares around here. So if you'd like to also share what your favorite fall comfort food is, you can give us all some inspiration for our September cooking. Please mute yourselves when not speaking, just to reduce background noise, and feel free to type any questions for our presenters or the PNQIN team into the chat during the webinar. We'll have question and answer time at the end. And finally, this session is being recorded, and we'll upload the recording and webinar slides to our website afterwards. Okay, so this afternoon, we are pleased to kick off the Perinatal Mental Health Bundle. Our mental health bundle lead, Dr. Tiffany Moore Simas, will offer some bundle pearls before we kick off into our two presentations for today from MCPAP for Moms and from Lowell General.
Good afternoon, everybody.
Thanks, Tiffany. So this is just a quick map and list of our participating hospitals. We're so pleased to see how many of you have turned out for this important patient safety initiative. And if your hospital is not on this list, there is still time to join. So just shoot us an email if you would like to join up. Just a reminder of what participation in this bundle means. We do have a few onboarding steps to kind of officially bring you on, and then afterwards, over the next year, we are asking teams to submit monthly data, attend these monthly webinars, or watch the recordings if you're not able to attend live each time. We're planning to put out a implementation feedback survey twice over the next year, just to learn from you all how implementation of the bundle is going and how we can assist you. We are going to be building in plans for sustainability throughout this bundle, so we'll be encouraging you all to think about that even as we start the bundle, and then to submit a plan as we near the end of this year-long implementation. And finally, we'll be inviting everyone to share their work with others as part of this collaborative. We have several teams like Lowell General who will be presenting their work on the bundle on these webinars, and also we'll have some information to share about putting together posters for our PNQIN Summit in December. We do have a advisory work group for this bundle like we've had with our previous bundles, and these are all the logos represented so far on our work group. Anyone is invited to join this work group. We meet monthly, and so if you're interested in just helping guide implementation of this bundle across the state, just shoot me an email, and again, everyone is welcome to join. So a few reminders for you all. There's far more information on these slides that I'm going to say out loud, but again, the slides will be available, and I'll be sending a follow-up email with all of this information. So a few quick things from PNQIN. Many of you have answered our PNQIN summer survey, and I just want to say thank you so much for doing so. This information is really valuable to us and is going to drive many of our activities and supports moving forward. If you haven't yet had a chance to complete it and would like to do so, the link is here in the slides. I believe Brooke is also putting it in the chat, and we're asking for any final responses by September 30th. Like I mentioned, everyone is invited to submit a poster to present at our PNQIN Fall Summit this year on December 9th in Norwood. We used to do poster sessions before COVID, and we haven't done them since COVID, so we're very excited to reinvigorate this practice. And we ask that the topic you share have a relation, whether directly stemming from or a similar topic to a past or present PNQIN project. And of course, we are a QI organization, so we also strongly suggest focus on quality improvement. We'll be sending out poster guidelines and a template for posters within the next couple of weeks. We also have a new page on our PNQIN website that our project coordinator, Brooke, created to display all the publications related to PNQIN's work as well as our partners' work. So if you have a publication and you're a PNQIN collaborator that you'd like to be featured on our website, please feel free to send the citation or a PDF to me at pinquinadmin@pinquinma.org. Lots going on in Massachusetts recently. For those who may not have yet heard, Bill H4999 has been passed and signed by Governor Healy. This is a landmark bill that will address racial inequities and aim to improve maternal health across Massachusetts. And the PNQIN team was so honored to be present for the signing in late August. And we're also excited to support the many activities that will be coming out of this bill. There's some free education available around perinatal health conditions that we welcome you to register for. This is a several-month-long learning series with free registration and CEUs available from HHS Region 1 Women's Health and the Mass PPD Fund. The Worcester Healthy Baby Collaborative is having an info event for families on Monday, September 23rd. There's a $25 gift card for those who attend, and light food and childcare will be provided. From our partners at the Institute for Perinatal Quality Improvement, they have given Massachusetts perinatal providers free access to their birth equity modules course. This course includes 4 30-minute web-based modules for those working to ensure health equity in their organizations. Free access expires on September 30th, so you have about 2 weeks left to get these modules for free. They're very thoughtfully put together, and we highly encourage anyone passionate about equity to take advantage. Our partners at MassPert TTA have a virtual course around learning skills for motivational interviewing starting also on September 30th. The training course is 5 weeks through November, and it's a time commitment about 4 to 5 hours per week. You can read a full course training description and apply in the links on this slide. Registration is now open for a fetal alcohol spectrum disorders training and workshop on October 29th and 30th in Boylston. More information and registration on the links below. And if you have questions, there's a contact email here on this slide. Day 1 attendance is required in order to attend day 2. Coming up in early December, there is an event at the Boston University School of Public Health called Health Policy, Community, and the Mississippi Delta. There's a virtual webinar at 1 p.m. and then an in-person reception where copies of Dr. David K. Jones's book, Ripples of Hope in the Mississippi Delta, will be available for everyone to take. A new publication is out from Dr. Fifi Jop, who used to be the principal investigator for PNQIN. She's written this in collaboration with many other PNQIN colleagues on severe maternal morbidity, and our hope is that you all will use the recommendations in the article to prevent future SMM at your hospitals. If you'd like a PDF, you can contact Brooke. Finally, many resources coming out from Mass Health recently. Again, this is a wordy slide, so I'll just say that Mass Health covers several remote patient monitoring codes, as well as transportation of a child's parent, family member, or caregiver that's necessary to the child's care, including an infant receiving care in the NICU. So if you'd like more information about coverage for these benefits, you can click on the links in the slide. Couple of national announcements for you, and then I'll turn it over to Dr. Moore Simas. So the Mama's Voices organization and the National AIM program are collaborating on a community of learning for hospital and outpatient providers. This community of learning focuses on effectively building a patient engagement and culture in your unit or practice. This is a 4-week program where you'll gather virtually with folks in the program I've taken this myself, and it's a really wonderful experience, and you'll learn a lot about working with patients and integrating their valuable perspective into your QI work. We also would like to share about a CDC Health Alert Network advisory on the Arapucci virus. PNQIN recently met with a team from the CDC about this health advisory, and so you can read more here, and there's also a link to the full advisory. So please keep an eye out for cases of this virus in your care. And finally, the March of Dimes 2024 Maternity Care Deserts Report has been released. March of Dimes is on the PNQIN Advisory Board, and so we do plan to speak with them about the impacts of this report for PNQIN's work. Phew, that was a lot. So much good stuff going on. I hope you all are able to take advantage, and now I'll turn it over to our bundle lead, Dr. Tiffany Moore Simas.
Hi, good afternoon, everybody. I'm going to really rapid fire go through a couple of resources as everybody, as we're sort of kicking off this webinar as the beginning of the year for bundle implementation, we thought it'd be prudent to upfront share a number of resources. There are a lot of resources that have been developed over the last couple of years regarding perinatal mental health. We can go to the next slide. Literally just going to sort of say what they are so you know they exist and you know they're out there and you can be looking for them as you start on this work. So of course, like all the patient safety bundles, AIM has other associated documents like the implementation guide, resources, data collection plans, and then the IHI change packet. We can go to the next slide. In addition, wanted to make you aware of some kind of locally created resources with national funds embedded across the US. So our Lifeline for Moms team at UMass created a perinatal mental health toolkit, which exists, you can go to the next slide, on both the ACOG website and the Lifeline for Moms website, free of, developed by obstetric care clinicians for obstetric care clinicians, lots of algorithms and very actionable information. Next slide. Also, with funding through the National Institute of Mental Health, e-modules were created. A number of those through the Learning Collaborative inquired about educational resources. So this is a self-paced, case-based, interactive design. Next slide. There's 4 components that takes you through kind of the mental health care pathway of detection, assessment, treatment, and follow-up. You follow 4 individuals. Again, interactive, case-based, self-paced, maximum of 2 hours, can do it quicker, depends on how much time you want to spend on it. There's resources, references, visuals and voice overs where needed, and highlighted summaries at the end. This is free through ACOG. There's CMEs associated with it. Can go to the next slide. And then there is an implementation guide that provides step-by-step instructions and resources for how to integrate perinatal mental health into obstetric care practices. It goes through the care pathway, uses a QI implementation approach. There's self-assessment instruments that you can sort of see where you are, help create SMART goals on where you want to go. There's recorded guidance, so there's lots of paper documents, and then there's videos to have the team help guide and implementation. There's templates for workflows and things of that nature. And again, available on ACOG and the Lifeline for Moms website. Next slide. And then so you have the toolkit, the e-modules, the guide, and this is my transition over to our MCPAP for Mom team leaders and colleagues, as MCPAP for Moms is our Massachusetts Perinatal Psychiatry Access Program and like the greatest resource as far as I'm concerned in doing this work and really being an in-the-moment partner as you're trying to implement and taking care of patients in the moment. So I will turn it over to our MCPAP for Mom colleagues.
Hi, everyone. Thank you, Tiffany, for the introduction and for the invitation. I'm Leena Mittal. I am a perinatal psychiatrist based at Brigham and Women's Hospital, where I am the Associate Vice Chair for DEI in the Department of Psychiatry, and also the Medical Director for Equity, Substance Use Disorders, and Community Partnerships at MCPAP for Moms. Next slide, please. So MCPAP for Moms, as Tiffany described, is a perinatal psychiatric access program. We historically are an offshoot of psychiatric access program that was originally designed for children's psychiatric issues to really support pediatric primary care providers, which is where the Massachusetts Child Psychiatry Access Program, the C in the MCPAP, comes from, but we are MCPAP for moms. And we exist with sort of a three-pronged mission that really focuses on education of all providers who are working with perinatal individuals with concurrent mental health and substance use disorders needs. We have a phone line where people can get real-time consultation with psychiatric consultants on the phone. We can either schedule a time or speak in the moment, as well as provide clinicians with resource and referral services to help support patients getting connected to services beyond the care they're receiving in their perinatal health setting. Next slide, please. Just to sort of provide a context for why we exist, I sort of feel like we're all pretty bought into the importance of mental health, but just to underscore, perinatal depression alone is the most common complication of pregnancy. And then we start to think about, like, if we expand our thinking about that depression is really only one condition, and we see so much comorbidity. So if you're thinking about anxiety disorders and executive function challenges and substance use disorders, we're really talking about an incredibly large proportion of the perinatal population impacted by mental health needs. But depression specifically affects as many as 1 in 7 women in the general population of perinatal people, though we also know that as you add other types of complexity like psychosocial, medical, et cetera, we really start to see higher prevalence. Next slide, please. Mental health conditions are now considered the leading cause of pregnancy-related death. So we have a growing amount of data from the maternal mortality review committees around the country to really cull our understanding of the contributors to pregnancy-related deaths. For many, many years, mental health conditions weren't part of the consideration of contributing factors, but as we've started to think about where they fall in contribution, those conditions have really risen to the top. So this is sort of a lumped view of mental health conditions, substance use disorder, intentional and unintentional overdose, for example. And we're really seeing the importance in most populations that if it's not at the top, it's the top 10, depending on how we break down the population of pregnancy-related deaths. Next slide, please. And specifically, when we think about some of our most marginalized and historically oppressed perinatal individuals and the people that we are working with, people of color are more likely to experience postpartum depression, but less likely to receive adequate care. So for example, in one study, African-American women and Hispanic women were more likely to demonstrate symptoms of perinatal mood and anxiety disorders as compared to white women in that cohort or population, but less likely to have engaged in care or actually made it ultimately been able to complete an appointment or treatment for their mental health needs. Next slide, please. And yet, we also have a lot of tips and tools to think about how to have these tough conversations about mental health. We're often at the individual level bumping up against a fair amount of misconception or misunderstanding or internalized stigma or uncertainty about how mental health treatment can look in the context of perinatal care. And so these are some of the things that I find myself as a perinatal psychiatrist saying over and over again, both to patients and providers in different contexts, that there are effective options for treatment during pregnancy and breastfeeding, that depression is very common during pregnancy and postpartum because so many people feel like they're the only one. Trying to remind folks that internally, we all may have different levels of resistance and stigma and thresholds for whether we take a medication or accept a treatment for all different kinds of indications or conditions. And so sort of asking ourselves why we might have a different barrier or threshold for mental health needs when mental health is really part of the larger health of a person. And then really reminding people that there is no risk-free decision and that mental health conditions themselves introduce risk to the pregnancy. And so we often focus so much on the risk of the treatment that we sometimes can have a blind spot towards the fact that actually the conditions themselves carry risk. Next slide, please. So how can MCPAP for Moms help? We are, as a psychiatric access program, available for real-time consultation during business hours. So we have an 855 number that providers or people working within the provider team, both inpatient and ambulatory, can call our line and ask for real-time provider-to-provider phone consultation. We also have, it's part of our educational mission, educational programming that can be scheduled for teams. We also have educational materials that is in the form of toolkits. The Lifeline for Moms toolkit was a collaborative effort that was that we at MCPAP for Moms contributed to, but we also have our own toolkits, especially we have ones that focus on substance use disorder and ones specifically focus on those substance use disorder providers who may be interested in addressing mental health and perinatal folks. And then we also have trainings around other content too, so mental health, trauma-informed care, psychopharmacology, so we can sort of tailor trainings and webinars and things like that, or we can come in person even to your team and provide these kind of educational opportunities. Beyond the phone consultation, we are also able to do some patient-based consultation, so provider to patient consultation after a phone consultation if the phone conversation between our consultant and the provider is not enough. And then additionally, we have resource specialists who are really, really savvy at being able to help people engage in treatment and support groups and a variety of other resources, and really help kind of serve as a navigator in a complex landscape of resources. Next slide, please. So this is just some examples of some of the resources we have on our website. Next slide, please. Who can call MCPAP for Moms? Really, the largest provider type we have calling our phone line are obstetric care providers and midwives. The second most common type of provider that calls are psychiatric prescribers, but really any type of provider who is in an ambulatory setting, has prescribing capacity, or they're part of their teams, can call MCPAP for Moms if they're working with perinatal individuals. And so primary care folks, pediatric providers, substance use treatment providers, family medicine. And we define at MCPAP for Moms perinatal as pre-conception, during pregnancy, and for the 1 year postpartum. And so really, like, the perinatal individuals can interface with so many different providers through the course of that journey. And so we're really here to support all of those providers. Next slide, please. So the way it works, if someone calls our 855 number, is that a resource and referral specialist will answer the phone call live as often as we can. Sometimes we do get flooded and we'll have to leave a voicemail, and we'll get back to you as soon as we possibly can. After a little bit of a brief conversation with our resource specialist, gathering a little bit of demographic information and a little bit of clinical information about the nature of the question and what is kind of the question at hand, you can make a decision about whether it would be helpful to speak to one of our psychiatric consultants directly, or if our resource specialist can work on getting resources directly sent to you. If you would like one of our resource specialists to work directly with your patient, we can also arrange that after a provider-to-provider phone consultation. After the phone consultation takes place, and it can take place in real time within 30 minutes of that phone call or at a scheduled time, it's essentially a curbside conversation that can take as long as makes sense for the clinical scenario and the time that you have. Our consultants are very understanding of the pace of perinatal care. So we are really doing our best to be as available to you as possible. If at the end of the phone call it makes sense, in kind of a shared decision-making approach, for us to see the patient, we can arrange virtual or in-person face-to-face consultation with one of our consultants and the patient. if we agree that this would help support that calling provider in ongoing care with that patient. And then we can also ask our resource specialist to reach out directly to the patient. Next slide, please. So the two ways that we can provide resources to a care team is either with a list of resources that gets sent to the provider with 2 to 3 targeted resources based on kind of a tailored, I often think of it as a curated list based on specifics that provider will let our team know. Or we can reach out directly to the patient and have one of our specialists have a sort of care navigation needs assessment conversation to really hone in on what they're looking for. And I think of it as sort of a hand-holding process, so sort of walk side by side. Next slide, please. So really our program mission is to promote maternal and child health, really whole family health, by building the capacity of providers who are working with perinatal individuals in order for all of us to be able to better address mental health and substance use needs in perinatal people. Next slide. I've included a few additional resources that we like to refer to, especially for colleagues who are not in Massachusetts and so wouldn't necessarily call MCPAP for moms. There are some national resources that providers and patients / help seekers, so that could be family members or other care providers or care or support givers, can call the National Maternal Mental Health Hotline, who's part of Support International, which has online support groups as well as a helpline. Next slide. I think there's a few more resources around substance use specifically. Jewish Family and Children's Services provides a lot. Their Center for Early Relationship Support is a really important service that provides both in-home and clinically based services. Next slide, please. Just a couple more. In fact, we can probably not sort of speak about all of the specifics, but you'll get all the slides just in the interest of time. I want to keep things moving. I think there's just maybe one more slide of other additional resources specifically for individuals impacted by substance use. And I think that's it. That's our last slide, I believe. So this is our contact information. Please do check out our website, call us on our 855 line during business hours, and we look forward to talking through any challenging cases as we can help. Thanks so much.
Wonderful. Thank you so much, Leena. If anyone has questions for Leena or the MCPAP team, please feel free to put them in the chat and we will address them during Q&A after our next presentation. So now I'd love to welcome Laura Federico from Lowell General to speak about their work so far on the mental health bundle.
Thanks, Callie. Hi, everybody, and happy afternoon, right? Good afternoon. We are kicking off, we were a part of actually the Mini-Collaborative, which started, I believe, in May of 2024, and have a full team. So we can go to the next slide, please. Just a little bit about Tufts Medicine Lowell General Hospital. Our labor and delivery has 12 units, 12 labor rooms, 2 ORs. We have an OB-ED, which is 3 rooms, as well as triage, 5 rooms. Our mother and infant unit is a 22-bed unit, and we also do have an open nursery. And special care is a 10-bed unit, and then we have a very large pediatric unit, which is 20 beds. Next slide. Just a little bit about our team. As we were developing our stakeholders, we wanted to make sure that we had a nice array of different disciplines on the team. So obviously there are some site champions and clinical leads, myself, as well as Lori McCall, who is the clinical leader of Mother Infant Unit, and Kristen Sparks, who is a clinical leader of pediatrics. We have providers. Kathleen Cullen-Letter is our certified nurse midwife, as well as a nurse practitioner, family nurse practitioner from Merrimack Family Medicine, which is our outpatient area that we really wanted to focus on with this collaborative. Many different members of the team, all of our managers. We have so many people who wanted to be on it. And we also have some some nurses who just drop in and give us feedback on any of our ideas that we started since May. We also have on the right side of the screen, you'll see that our anti-racism statement that actually our educator, Sarah Thibodeau, worked on in the birth equity PNQIN project that they had a few months ago. It just ended, I believe. Next slide, sorry. So in the collaborative, we were asked to choose a process measure that we wanted to focus on. The bold statement here, the patient education on perinatal mental health conditions, which is disaggregated by race, ethnicity, and payer, is what Lowell General chose to focus on. In our division, as we spoke with our stakeholders, we realized that we really talk a lot about postpartum depression, especially on the mother and infant unit, but we didn't have universal education throughout our MCH division. And we certainly did not talk about the mental health conditions, as we are now changing our focus from that postpartum depression or the baby blues to really talking about the perinatal mental health condition. I mentioned the outpatient work, and as we talked about, and we had so many different ideas, a common theme throughout them was always the outpatient areas, and how do we get engagement from our outpatient practices and communication between our inpatient world and the outpatient world. So that is a focus for us as we move forward. We understand there's limitations in the offices due to staffing. Our clinical leader of mother infant unit, Laura McCall, who's one of our clinical leads, did work in an outpatient office. So she's able to give us a lot of insight on some of the obstacles that they face. And some of them, obviously staffing, which is I think universal everywhere, but also the lack of social work services in the offices have been identified to help support our mothers. Next slide, please. So this is our SMARTY goal, and I think Callie and our other coach for Lowell General was Mimi, in helping us create the SMARTY goal and really fine tune it a little bit. I think when we first got together in May and June, as we started developing our program, we had so many different ideas. We had a hard time really focusing on a few, but speaking with them and really targeting one area, we wanted the education. We knew we had to start with the education. And we talked about what's the best way to educate and what is something lasting that these mothers, but also the families can take home with them. Our mothers and families get so many handouts when they are in our mother and infant unit, or they're welcoming packets on pediatrics. We think a lot of it is lost, that they're not actually reading all the materials. So we went with a magnet. We chose to look at and design a magnet to talk about the perinatal mental health conditions, the signs and symptoms, in the hope that the magnet would be displayed at home in whatever way they could. And family members, friends who are coming to visit would also see those signs and symptoms and talk to the mom. And also we wanted a QR code to link to a site for additional support. We chose the Postpartum Support International site to link to. I think there's 60 different languages available, phone line languages. And we thought that in our community of Lowell, very diverse, we wanted to try to support all different languages. We primarily started with 3 languages for our magnet, English, Portuguese, and Spanish. Since implementation of creating the magnet, we actually added Haitian Creole as well as Khmer. So we're very proud of that. And we want to start passing it out to 95% of our patients is really our goal, to all patients, regardless of race, ethnicity, or payer. Next slide, please. And this is our driver diagram. I know it's a little blurry. I apologize. This is actually what Mimi and Kelly really helped us fine tune on. The education piece is is really looking at educating our nurses and making sure that they can speak confidently about the different perinatal mental health conditions. And there is going to be a handout on the far right side under change concepts on the top. It does say paper handout. We did want to also realize that there's different learners. There's some that are visual, but there's also some that retain better when they're reading. So we do have a handout to support the magnet as well. We do have Epic is our electronic medical record, and we are looking to integrate our education, our documentation that we have educated through Epic, and that is a little bit of a challenge, and it takes a while to get things done and built in Epic. So we're tackling that in the bigger collaborative. That's one of our goals. And then we created a PowerPoint, a full-fledged PowerPoint. It's wonderful. It has a pre-survey and a post-survey, hoping to see some improvement in the post that they did learn something in this PowerPoint. And we're going to push that out to all of our MCH division. When I say MCH here at Lowell, it encompasses Lowell labor and delivery, mother and infant unit, special care nursery, and pediatrics. And once we push that out, our then next step goal is to get this to the OB providers. And hopefully they can retain some of this as well. We're creating a the ability to track. So I'm sorry, with Epic, the ability to track and pull trends is what we want to try to pull from the data. Once we build it in Epic, we can then hopefully create some reports. And I think that's it on this slide. Kristen and Lori, I know you are on. If there's anything you want to jump in and say, please feel free. And next slide. And this is just our timeline from May to August. We established our team in June. We created one version of the magnet. You'll see it in a couple slides. We have some samples of what we had. And then the handout. In July, in August, we started creating the PowerPoint and fine-tuned it towards the beginning of August. The magnet had to go to our Tufts Medicine marketing team for branding, which we were unaware of, so we learned something there too. And we had it translated in 5 different languages, like I had mentioned. In August, which actually, it says August, but it's with all the issues getting it onto our learning management system, we're actually kicking it out this week to our MCH nurses and staff to take, and we'll give them 30 days to complete the PowerPoint and the learning management system. And yes, Grace, the magnet is coming. You'll see it. Next slide. We also offer trauma-informed care. One of our stakeholders is a champion in trauma-informed care. And years ago, we had it mandatory education. It's probably 8 years ago now through our MCH division, but we have a lot of new nurses that, as we were talking about our program and education, we realized that a lot of them were lacking trauma-informed education. So we have implemented this mandatory education. It's I believe it's a 2 to 3 hour class that one of our clinical leader on labor and delivery is teaching to all of the staff. And she would eventually like to push it out to the OBs and midwives to also attend as well. Next slide. So this is our very first version of our magnet, which we all love. We thought it was perfect. We just created it based on those signs and symptoms and the QR code link. And then we realized we had to get it approved. So of course that this lovely picture didn't stick. So next slide, please. So our first version of our magnet, we have a mother support group here at Lowell General that meets every Tuesday for 2 hours. And we wanted to see if these moms, I think out of the 7, 6 of them had delivered at Lowell General. So we were able to get feedback. We wanted to ask them what was discussed in their postpartum education regarding postpartum depression, and would this magnet be something they would hang at home? Would this be something that they would find useful, just to get some feedback? I know the N is a small amount, but we wanted to try to get some immediate feedback, especially where the Mini-Collaborative was only from May to August. We were trying to move pretty quickly, and we thought this was the best format to ask our mothers who delivered here. And we got some good feedback in regards to, they all thought it was visually appealing. They agreed it was easy to read. They would use it at home, which I think was our biggest thing. And they thought the resource was easy to understand, and just one thought it was difficult. So I think overall it was well received. We just needed a bigger group. I think it would have been beneficial if we had more people give feedback on it. Next slide, please. So this is what they came back with, which is great. It's our branded version through the test marketing, and just made it all purple, so it does pop in this instead of circles. Just the signs and symptoms of what to look for are there. And the QR code, like I said, goes to the Postpartum Support International site. Next slide, please.
Laura, can I just mention one thing on that QR?
Yes.
Yep. Where we have it in 5 languages, that QR code actually will take, depending on what language, you directly to the Postpartum Support International website in that language, so they don't have to search for it.
Thank you so much. That is a really big point that we were happy. I think there was just 2 languages that they didn't have a website for, so that they just go there and they get the language when they call the hotline. But other than that, you're right, Kristen, that's great. Thank you. And our marketing department was able to have different QR codes for that. So that was great for them, for us. Next slide. So our future direction is our survey to staff that I mentioned regarding the comfort level, speaking about postpartum mental health condition. And Lori, I believe you gave that out before you created the PowerPoint, correct?
That's actually the beginning of the PowerPoint. One of the questions is, how comfortable are you speaking to perinatal mental health conditions? And then they will go through the PowerPoint of education, and that question's in the post test as well to see if they're more comfortable.
Perfect, thank you. And then our next step is staff education on conducting the Edinburgh screening for all postpartum mothers. So currently here, we do not offer the screening to our postpartum moms. But as I've attended and we've been doing our additional resource, a lot of our postpartum units in the state are giving the Edinburgh screening to our moms. So we need to work on education to staff to sitting down with our moms and going through the questions with them, scoring them or screening them. And then we all know that there's a number associated, and then what to do with the number. If it's too high, making sure social work is involved. So there's steps that we will need to do. We also, obviously the perinatal period goes until 1 year of age. So our pediatric population, our moms that come into PD, those are our moms that really are experiencing it, if they are during that time frame, up to 1 year. So we want to be able to give it to the screening tool to our moms on PD, but then they're not patients. So our obstacle is, how do we address that in the babies chart in Epic, which we don't think we can do. How do we help our moms? Do we contact the OB or their PCP at that point and talk to them? So there's lots of different pieces that I'm hoping this collaborative right here can help us in giving us some resources that maybe other units who are already doing it can help us here at Lowell with that. We want to continue to expand our magnet in different languages as the community dictates. Different whatever languages, we were very easy to flip those into different languages. So I'm happy to have that. Ongoing chart audit. So we again in Epic, we needed to find where we could document this. So Lori and Kristen have gone into charts and have determined how they're going to educate staff on where to track it until we can put it into the flow sheet. And it's just educating staff now on how to do that. And then, like I said, the future direction is to get this PowerPoint that we have created out to the OB providers and then all the staff members in those outpatient offices. Next slide, please. One other thing we learned is, again, the visual for family members, for friends. And we like to use the term, which I found when I attended a conference on this, is mothering the mother. And we always forget, you know, the mother goes home and there's no nurses to take care of her. That help is missing. So it's how can we help mother the mother? And this poster on the right side, the self-care, it gives people who are visiting specific things to do. And also family members, anybody can say, hey, you need to go sleep right now. I'm gonna hold the baby, or I'm gonna do your laundry. So it's really, we're creating these two pictures that you see on the left side and the right side. We're going to create posters, small posters that we like, almost clings that can go on the walls. On pediatrics, we're laminating them and we will just clip them to a magnet to put on their whiteboard because it's only for those patients who are under 1 year of age who would be in the pediatric unit that we'd want them to see this. So that's future. I think it's almost done. We're just not quite completed yet. Next slide. And then challenges, I've mentioned a few, getting buy-in from all of our outpatient offices. We think that will be, actually, we probably know that's going to be a challenge. Edinburgh in Epic, it is already built in Epic in the Epic system. There is a new US version, which I, again, attended a conference where this, it's a validated version. It just tweaks question number 6. Into verbiage that is just more from the feedback they got in research. It's a simpler way to ask the question. And then there's also some other additional experiences on that sheet that may trigger some feelings of depression that they wanted to have on the form. So there's that version out there, but Epic has the old version already built. So which one do we use? The US version is only in English right now. Spanish is coming. And I do have permission to get it translated into other languages. So it's just us trying to decide which way we want to go. I mentioned the different languages. The nurses' time in reviewing the Edinburgh. So for us here at Lowell, we currently don't have that embedded into our process of on the postpartum units or on the pediatric unit. So it's an ask. It's something different. You know, nurses have a hard time with that change. So it's going to take time because it is something you need to sit down and go over each question with the mom. There is a handout that I have. I think it's called PMH Connect that was with the US version. And it does give guidelines on resources and also how to go through the tool with the patient. So, but again, that's going to be an ask of the nursing. Documentation for Epic for a parent who's not the patient. I've mentioned that. And then the data collection, we are having a little bit of an issue getting the payer piece out of Epic right now. We can get the race and ethnicity, but the payer piece is a little bit of an issue right now. So we're working on that. Next slide. Oh, there you go. I ended perfect on time, Callie.
You did fantastic, even 1 minute sooner on my clock. So thank you so much, Laura. That was incredible. Wonderful. Yeah, everyone. So much good content presented here. We have a full 10 minutes for Q&A and discussion. I'll turn it over just briefly to Dr. Tiffany Moore Simas for any just comments on what we've heard so far and to open it up for questions.
No, I'm grateful that this is the start of the year in which we're going to sort of proceed with the perinatal mental health conditions bundle implementation across the state. I'm so thrilled that there's so many people on the webinar today and that there's so much interest. I remember back to the 2015, 2017 time period when the bundle was originally created. And I would say we've come a long way, both in awareness and interest and activity around this, along with resources. Thank you to Leena, Dr. Mittal, and the MCPAP for Moms team for being a part of the solution for over 10 years now, and for really supporting us all in doing this in the past and going forward. And thank you to the Lowell General team and Laura for your wonderful presentation. The magnet, it's like, these are the types of things that in fact increase the awareness and get us to the next steps. You know, and once we increase awareness, we'll talk about this over the next year too, right? Whether it's increasing awareness through screening or through these sort of public education type opportunities, we'll also then walk us through, you know, assessment and treatment and really getting perinatal individuals the help that they need. So I'd just love to open up to questions. Anne-Marie?
It's not a question, but I just want to know, I think an impactful story is, I'm Anne-Marie from Lowell. Even though we haven't educated the staff yet, I do patient rounds each week and I do hand out the magnet to patients. So some of our patients have gotten it. In the first week that we handed this out, and I have a conversation with them about what intrusive thoughts are, because that is on here, kind of defining that. And we actually had a patient call at 2 a.m. saying she had intrusive thoughts, and we were able to act and get her to our emergency room. So I just wanted to kind of give that impactful story, that just something so small that we started with this magnet, we know we've already impacted one family.
So I'm just reading the chat. So Sarah Krajewski is saying, oh, they're coming in fast. Where'd it go? What do you find to be the best inpatient postpartum screener for depression and anxiety? Is the EPDS what's best? Leena, I'm wondering if you want to field that question.
Yeah, so I think what is most important, I think, in the inpatient experience is really having a conversation and really providing psychoeducation about what to expect. Most of the data about the Edinburgh and really all screeners, as far as I'm aware, really is that that time is so full of confounding experiences. So like that early those days immediately postpartum, just after delivery in the hospital are really, it's hard to kind of disentangle the physical symptoms, the sleep deprivation from potentially an episode of a mood disorder or an anxiety disorder. And so really it's about psychoeducation and talking about ongoing follow-up, ongoing support and monitoring, and less anchored on quantitative measurement-based assessment. And that's really the approach I take. I will also say, just to, given the group here, I would say antepartum, similar thing, though I think those scenarios are slightly different than kind of all of the confounding factors associated with delivery and the immediate postpartum days after delivery.
Yeah, thank you. I know there's you know, the ACOG's recommendation is around screening, you know, twice in the prenatal period, ambulatory, which is, you know, initial OB visit, later in pregnancy, which is not required to be sort of timed to the gestational diabetes screen, although a lot of people are sort of doing it at that time point, which is, you know, very end of second trimester, early third trimester, and then in the postpartum period. There isn't an express recommendation around delivering at postpartum discharge or the, you know, delivery and postpartum visit. However, right, that is sort of a common experience, right? If you didn't get prenatal care, but many people will deliver in the hospital. So there's a lot of interest, a lot of people doing in that. But as you know, just to lift up what Leena is saying, most of the screeners are not really validated in that time period, and there's such a high rate of postpartum blues. So there's the sort of real strength is in the conversation, the psychoeducation, and really opening the door up to, if you have any concerns about what you're thinking or feeling, please do contact us. A lot of interest in the magnet and curiosity around, is there an opportunity through DPH or otherwise to do something that could be distributed and not everybody recreating the wheel? Thumbs up, thumbs up, pointing up. So a lot of interest in that. It sounds like a takeaway conversation. Grace, did you have your hand up?
I was just going to say that I think even if we don't have good data on offering the screening at postpartum discharge, it opens up the opportunity if the person giving the screening knows what conversation to have for that conversation you were mentioning to happen, and that's valuable.
Yeah. So what I totally agree with the idea of creating space for the conversation. The concern I have with specifically to like administering a screening tool is the risk that that tool, that number gets kind of ascribed a meaning that it may not have. And so like we could call this a quote unquote false positive. I don't love that term because I think what someone is experiencing is never false. It is true to them. And positive and negative, I think, are challenging and problematic in the context of mental health. But I do think that ascribing a number on and a score that then gets recorded in some flow sheet somewhere is really different when we don't think that that score is necessarily fully reflective of like what it's usually ascribed to. So I think it's about the space and the conversation and the training of the person having the conversation much more than it is about like the metric of the questionnaire and then that number and saying like what's positive and negative and all that stuff. So like that would be my caveat with using the questionnaires specifically.
Yeah. There is similar, just to add to that, similar, there's sort of talk about, you know, every time we ask, however we do that, there's also, you're kind of decreasing stigma and opening the door and just, you know, making it clear that like, we want to hear about it, right? We want for people to come and share their experiences and help, you know, open that door for further evaluation. Right. Other questions or thoughts? Callie, do you want to close us out?
Sure. Thank you so much, everyone, for being here today. We will be having these webinars monthly, and I'll just put my screen back up really quick. And our next one is coming up on October, I believe it's October 15th, actually, where these webinars are the third Tuesdays of the month. And so our next one will be October 15th. And like I posted in the chat before, we're so pleased to have members from the Massachusetts chapter of the Postpartum Support International joining us for that webinar. So we hope you all are able to make it. In the meantime, keep an eye out for a follow-up email from me with the slides and webinar recording from today, as well as all the announcements and resources that we provided. We hope you all were invigorated by this very first webinar and are excited to do this bundle with us. So thank you so much. We'll see you next time. Take care, everybody. Have a great rest of your week.
Thank you.